All right, so thanks so much for being here this morning, guys. I think I know pretty much everyone here. But for anyone I don't know, my name is Thara Kumar. I'm one of the senior residents here in the Emerge. So thanks a lot for coming. My topic today is an opioid clinical update. So this is an update on the opioid crisis in Canada, but specifically looking at it from a clinical emergency room perspective. Now, we've all seen these headlines. We know that this is one of the largest public health crises affecting Canada today. You really can't open a newspaper or turn on the news without seeing headline after headline about this crisis, about another fentanyl-related death, about another massive drug seizure. And actually, Ottawa hosted the National Opioid Conference and Summit just on November 17th, where medical experts were urging the government to officially declare this a Canadian public health emergency. But unfortunately, this is more than just a public health problem. This is our problem as clinicians right now. As frontline health workers, we're feeling the effects of this crisis on our patients and in our practice on a day-to-day basis. We're seeing higher numbers of opioid overdoses and opioid withdrawals coming to the Emerge than ever before. We're finding that our previously reliable antidotes are not working the way they once did. And we're finding that these resuscitations are becoming increasingly complex. So here's what I kind of want to focus on this morning. If I can only achieve one thing today, I hope it's to actually convince you that this is an Ontario problem now. I think we've been lucky to be a few steps behind in this epidemic, but this is no longer just a St. Paul's emergency problem or even a Western Canada problem. This really is an Ontario problem now, and so we need to be prepared as Ontario physicians for what's coming our way. I want to go over the management of opioid overdose. Again, this used to be a really easy overdose to treat. The signs and symptoms were clear, and we had an antidote that worked really well. But now we're finding that with more high-potency opioids in the mix, like fentanyl and carfentanil, and more cocktails of opioid-laced ingestions, we're seeing that these are getting harder and harder to treat. So we're going to talk about how to dose naloxone in the setting of new high-potency opioids. We're going to talk about what complications to look for in these patients. And we're going to talk about how to assess for safety for discharge. And then finally, we'll go over the management of opioid dependence and withdrawal in the emergency room, and some tools beyond just clonidine that you can use to try to treat these patients. So we'll start off with a little bit of epidemiology of the opioid crisis, and I'm not going to bore you here with a whole bunch of statistics. I just really want to emphasize the scale of the problem that we're dealing with and why everyone is so concerned about this. We all know that St. Paul's ED, which is near the now infamous East Hastings district in Vancouver, has kind of been the epicenter of Canada's opioid crisis. And a big part of that is just geographical. It's the closest port city in Canada to China, and we think that most of the illicit fentanyl and fentanyl precursors are coming in from China. But the number of opioid overdoses occurring in that part of the country are absolutely staggering. St. Paul's ED is routinely seeing 20 to 30 opioid overdoses per day in their department. Now, I don't expect, and I certainly hope, that we're not going to get to that level, but all of the numbers suggest that Ontario and the rest of the country are following not that far behind. We're seeing huge increases in opioid-related toxicities in our EDs and throughout the country. The Canadian Institute for Health Information released a report in 2016 tracking emergency visits and hospitalizations due to opioid poisoning between 2010 and 2015. And this figure, which is taken from that report, shows the rate of hospitalizations due to opioid poisoning in the year 2014 to 2015 in Canada. And the specific numbers on the chart aren't really important, but I think it nicely demonstrates just the widespread effect that this epidemic has had on the country. No province is immune to this. The CIHI report found some really shocking numbers. There are 7 visits to the emergency room every day, just in the province of Ontario, for opioid poisoning. There are nearly 13 hospitalizations per day for opioid toxicity across Canada. And on average, each one of those admitted patients is staying in hospital for an average of 8 days. And that's longer than the average length of stay for myocardial infarction, for pneumonia, or for hip replacement. So the burden of this epidemic on our healthcare system is huge. To put this into some context, we all remember that in 2003, SARS completely paralyzed the Ontario healthcare system. And it was the last public health emergency that was actually declared here in Ontario. In total, SARS caused 44 Canadian deaths. In comparison, estimates from Ontario Health Minister Eric Hoskins suggest there are currently up to 49 Canadians dying per week from the opioid overdose. So those comparisons are pretty impressive. And finally, just to compare to something that we're a bit more used to seeing in our department, preliminary numbers from Ontario Provincial Police suggest that there were 299 deaths secondary to motor vehicle collisions in Ontario in 2015. But in that same year, there were 529 deaths recorded in Ontario due to opioid overdose. And in 2014, for the first time, fentanyl was actually the leading cause of Ontario's opioid-related deaths. Even here in Ottawa, data from EMS suggests that our colleagues in the field are seeing huge spikes in calls related to opioid-related overdose or death, even just in the past couple of years. This graph demonstrates the number of patches seeking Narcan by Ottawa paramedics over the past 3 years. As an aside, you might remember that on December 23rd, 2016, ACP paramedics no longer had to patch in to give naloxone. So now they can give naloxone of their own directive, and that was changed as a direct result of the increasing demand that they were seeing in the field. But this data all comes from the time when paramedics were still patching in for naloxone. So on this graph, the blue line represents 2014, the red is 2015, and the green is 2016. And we can clearly see a significant increase in the number of patches for naloxone from year to year, and particularly in the second half of 2016. In fact, the total number of patch calls nearly doubled from 64 to 112 just over a 2-year period. And while we don't have any data specific to death secondary to opioids, Ottawa paramedics recorded a total of 20 vital sign absent calls in 2016 that they thought were due to drug overdose, and 16 of those calls actually resulted in death. And that compares to only 3 deaths due to drug overdoses in the year prior. So all of this is suggestive of both how increasingly common and increasingly severe these overdoses are becoming right in our own backyard. And further highlights that Ottawa has not been immune to the sweep of the opioid epidemic that's happening across the country. Even more worrisome for us is how rapidly this problem is evolving. The so-called high-potency synthetic opioids like carfentanil and W18, which are thought to be up to 100 times more potent than fentanyl, were up until recently only a hypothetical risk that had been found in a few isolated pockets in Alberta and British Columbia. But following the same pattern we've seen for all the other narcotics, carfentanil was discovered in Ontario just a few weeks ago. And the discovery brought with it a frenzy of unanswered questions. How much naloxone are we going to need to reverse a carfentanil overdose? Is it possible these drugs will eventually actually exceed the ability of naloxone to reverse them? And how do we protect our frontline care workers? All of these questions, which were not so long ago only theoretical discussions, are suddenly not so theoretical anymore. So all that to say that we are indeed past the point of hypotheticals now. This crisis is real, and it has arrived at our doorstep. So we need to be prepared in terms of dealing with what's coming. So with that in mind, I want to talk a bit about managing the acute opioid overdose in the department. And a lot of this will already be familiar to you. This is an overdose that we've all seen. But there are a few management adjustments that I think we need to start making in the context of the opioids that we're seeing now. So let's consider a clinical scenario first. You're working in recess at the Civic and a patient arrives via EMS. She's a 24-year-old female who is found unconscious outside of the Mission Shelter downtown. Her friend who is with her endorses that they were injecting tabs of what they thought were oxy. And then her friend passed out. She's GCS 6, pupils are pinpoint and non-reactive, skin is dry and cool to touch, and her lips appear purple. Her vital signs are as you see there, the most significant abnormalities being a respiratory rate of 8 and an O2 sat of 94%, and she's currently being bagged by EMS. She received 0.4 milligrams of IM naloxone by EMS with no apparent clinical response. So in terms of what to do next, we go back to what we do for every resuscitation case. We still go back to our ABCs. And don't forget to think about universal antidotes in this context. So in addition to naloxone, you'd want to consider things like getting a glucose check and applying supplemental O2 while you're sorting out what's going on with this patient. Now, airway and breathing tend to sort of go hand in hand, especially in these patients. The respiratory arrest that's induced by the narcotics leads to a hypercarbia and a CO2 narcosis. The CO2 narcosis causes the decreased LOC, which is what leads to a potentially unprotected airway. And that's why for these patients, early and aggressive bagging is really important to try to eliminate that CO2 narcosis. And that will actually buy you enough time to administer a dose of naloxone. It allows you to better assess how your naloxone has worked on the patient, and potentially it allows you to avoid an intubation. In terms of circulation, these patients are often mildly hypotensive, but they do respond well to fluid. So you can give a liter or two of fluid up front. And for disability, you're really just doing a quick screen to get a look at pupils, limb movements, and motor tone. And that's just to assess for any existing deficits, if there are any. And also to get a clinical sense of if this is consistent with a purely opioid overdose or if you need to be thinking about any additional toxidromes. Exposure, as always, is an essential step, but particularly in these patients, you really want to make sure you undress them from head to toe. And with that, you're looking for things like track marks, you're looking for any loose syringes, and most importantly, you're actually looking for fentanyl patches. You really don't want to be the guy who intubates someone because naloxone's not working, only to have ICU come down and pull the fentanyl patch off their back. That'd be a little awkward. And just keep in mind that the diagnosis of opioid overdose in the ED is strictly a clinical diagnosis. So there's no lab test that's going to help you diagnose this in the time frame we're dealing with in the eMERGE. And I know that no one in this room would ever order a urine tox screen, but just in case one ever gets sent before you can fling your body over the tube system and stop it from going through, just keep in mind that a few of the high-potency opioids, especially fentanyl and methadone, are not picked up routinely by our urine opioid drug screen. So if you clinically think a patient looks opioid toxic, don't let a negative opioid urine drug screen steer you in the wrong direction. Okay, so going back to our clinical scenario, we now have this patient who is presenting in a clinical opioid overdose. Her vitals remain unchanged. The rest of her exam is non-contributory, except that you find some track marks there. And her glucose is 7. So at this point, is it worth trying more naloxone? And how much more are you going to give before you call it quits? So let's talk a little bit about naloxone first. Naloxone is essentially a competitive opioid antagonist that works at mu, delta, and kappa receptors. It does not have any agonistic or morphine-like characteristics, but it actually displaces bound opioids from their receptors and takes their place, effectively reversing any of the opioid-induced symptoms. It is not known to produce any tolerance, and it basically has no effect on a patient who's not actually taking opioids. Naloxone has a very poor bioavailability when taken orally, only about 5 to 10%. But it's well absorbed through pretty much every other route you can think of. So you can give it IM, sub-Q, IV, through an IO, through an ET tube, or intranasally. The IV and ET tube routes have an onset of action of about 1 to 2 minutes, and most of the other routes of administration take effect in 5 to 6 minutes. The duration of action ranges from 20 to 90 minutes, again, depending on the route of administration and the dose. The indications for giving naloxone are actually really straightforward, and they're purely respiratory driven. So you're pretty much looking at the patient who you think is opioid toxic, who has a resp rate less than 12 or an O2 sat less than 92%. And a key point here is that decreased LOC is not an indication in and of itself to give naloxone. So if you have a patient that you think clinically has decreased LOC due to opioids, but they're still breathing fine and they're still satting fine, in that patient you can just wait. You don't have to do anything aggressive. Similarly, your treatment targets are just to reverse those factors. So you want to get their resp rate over 12, get their O2 sat over 92%. And again, your goal is not to wake them up completely. The key is kind of to try to find that sweet spot where you've woken them up enough that they're breathing on their own, but not so much that you've pushed them into an acute withdrawal. So our patient in this scenario is clinically suspicious for opioid overdose. Her resp rate is 8, and she's actively being bagged. So she would certainly be a good candidate for naloxone. But how much do we give her? She's already had 0.4 milligrams IM without much of a response. Now, in the past, the standard dose of 0.4 milligrams was sufficient to reverse most of the toxidromes that we were seeing. In fact, due to concern that 0.4 milligrams might actually be too high of a dose and might push chronic opiate users into withdrawal, most toxicologists recommend the starting dose should actually be a tenth of that, or 0.04 milligrams. And most of us here that I've seen will usually give 1, maybe 2 doses of 0.4 milligrams. And if that doesn't work, we sort of move on to other parts of our resuscitation. But literature is suggesting that that might not be good enough anymore, and that with more potent opiates circulating in the streets, larger and larger doses of naloxone are being required to reverse these patients. In 2008, a paper was published in the Journal of Clinical Toxicology by Schumann et al., following the 2005-2006 fentanyl outbreak in Chicago. This is a retrospective chart review that looked at the charts of opioid overdoses seen in the ED between April 2005 and December 2006, and that captured the peak of the opioid epidemic in Chicago. The study is not without flaws, being a retrospective review, and they also couldn't clearly identify which of their patients had taken fentanyl versus which had taken other opioids. But that is somewhat reflective of the situation we usually find ourselves in, where we have a patient who's clinically opioid toxic, but we're not sure exactly what they took or how much they took. And without much other previously published experience about fentanyl outbreaks, this paper has served as a bit of a guide for public health officials and clinicians in terms of what we might be up against now. So the Schumann paper found some pretty surprising numbers. They found that only 15% of the overdoses they looked at over the 21-month study period were successfully reversed by the standard dose of 0.4 milligrams of IV naloxone. 10% of the overdoses in the study actually required doses in excess of 6 milligrams of naloxone to be fully reversed. And on average, during this period of high fentanyl prevalence in their street drugs, the average dose of naloxone required to reverse a street opioid overdose was 3.4 milligrams of IV naloxone. Now, this is by no means an RCT, but it does give us some suggestion that in settings where there's a high prevalence of fentanyl in street opioids, that it's not only reasonable, but probably necessary to give much bigger doses of naloxone than what we're used to. You'll see a lot of different recommendations from different textbooks and experts about how best to titrate up your naloxone dosing. And the truth is there's no exact correct formula. But this algorithm comes from Edward Boyer in a study that was published in New England Journal in 2012. And it's fairly reflective of most of the algorithms I've seen other experts talk about or that are used in other EDs across the country. This algorithm suggests a starting dose of 0.04 milligrams of naloxone in adults and 0.1 milligrams per kilogram in pediatrics. And the reason that the ped starting dose is so high is because, firstly, pediatric patients are at much higher risk of a respiratory arrest if they're not treated rapidly. And secondly, they're at much lower risk of being pushed into withdrawal because most of them are not chronic opiate users. But from there, the dose is rapidly titrated up every 2 to 3 minutes, titrating again to effect on their respiratory rate. And I'll just emphasize here again that you're not necessarily looking for your patient to wake up. You just want them to start breathing again. So the suggested escalation of doses would be from 0.04 to 0.5, or in our center we'd probably do 0.4 because that's what our amps come in, and then up to 2 milligrams, 4 milligrams, 10 milligrams, and finally a maximum of 15 milligrams. And at 15 milligrams, if you're not seeing any effect on your patient, at that point you probably want to consider other causes of respiratory depression. So as you can imagine, one of the changes we might need to consider in our ED is stocking the actual vials of naloxone instead of just the amps, because otherwise giving 15 milligrams is going to be a very painful process. So that might be something we need to think about. Also remember that the decision to intubate a patient is a clinical decision, so that can be made at any point along this algorithm that you think is the right time. So what about naloxone infusions? Who actually needs them and how are they used? Naloxone infusions are being used fairly significantly in Calgary, Vancouver, and Toronto. I've only heard of a couple being used here so far. But they're being used to treat patients who have recurrent apnea in the setting of an opioid overdose, despite an initial response to naloxone. So the most important thing to remember here is that the naloxone infusion gives you a prolonged effect of the drug, not a stronger effect of the drug. So you're giving far more naloxone in your single bolus dose than you are in your infusion over time. So if your bolus hasn't worked to revive the patient, the infusion's not going to add anything. But for the patient who's needing recurrent doses of naloxone every 30 minutes to keep them breathing, the infusion can be really helpful. And in order to dose a naloxone infusion, you would take the total bolus dose of naloxone that was required to get your patient breathing again, and you would take 2/3 of that dose per hour as an IV infusion. So for example, if it took 2 milligrams of naloxone to restore breathing in your patient, then you would make an infusion of 2/3 that amount, or 1.3 milligrams per hour. And in terms of disposition, once you've initiated a naloxone infusion, you're pretty much calling for an ICU bed at that point. So finally, after all your acute medical management is done, and you're left with a relatively stable patient, we're left with a really important question of when can this patient be safely discharged home? And there's a lot of different factors that need to be considered when making that decision. Unfortunately, there's no one clear-cut number that's going to work for every patient or for every scenario. But I think there's 4 key things that you need to consider when discharging these patients. The first is consideration of the pharmacokinetics of the drugs that are involved here. So the duration of action of naloxone, as we discussed, ranges from about 20 to 90 minutes. But the duration of action of most opioids can range anywhere from 1 to 24 hours, again, depending on what type of opioid, the route of administration, whether it's an immediate release or extended release preparation, or any co-ingestions that might alter the pharmacology. Regardless, there's a good chance that an ingestion of opioids significant enough to require naloxone may have an effect longer lasting than your bolus dose of naloxone. And that's why naloxone should never be used as a means to sort of wake up the overdose patient and get them out of the department quickly. You want to at least monitor them beyond the duration of action of naloxone to see if they're requiring repeat doses to sustain breathing. The second consideration is how the pharmacology of opioids changes in the setting of an overdose. So large doses of orally ingested opioids have the potential to form a GI bezoar. And so that can result in erratic rates of drug absorption, decreased GI motility, and delayed gastric emptying. So with that, you get prolonged rates of drug absorption. Opioids, especially extended release preparations as well as fentanyl, are also highly lipid soluble. So in very large doses, there's a risk of absorption into tissues and then delayed release into the bloodstream at a later time. And that can have effects sometimes for more than 24 hours. And finally, in the setting of overdose, the elimination kinetics of opioid analgesics changes from first-order kinetics to zero-order kinetics, meaning that instead of eliminating a constant proportion of your drug per unit of time, you're now only eliminating a constant amount per unit of time, which will significantly prolong the elimination time and potentially increase the duration of action of your opioids. Now, this figure was taken from that Boyer paper in the New England Journal, and it depicts the difference in hours of effect between therapeutic doses, which are represented by the blue bars, and overdoses, represented by the red bars, in various opioid formulations. Now, this data is an amalgamation of data taken from case reports of overdose, observations from clinicians and clinical toxicologists, and forensic data. And again, this does not come from RCTs, so take it with a grain of salt. But it does demonstrate the huge potential variability in action, duration of action of opioids between therapeutic and overdose ingestions. Based on this table, we would have to monitor some overdose patients for more than 24 hours to be sure that the opioid is completely out of their system. And obviously, from a clinical perspective, that's very rarely going to be a reasonable thing to do. And actually, our goal is not to watch these people until every last bit of opioid is out of their system. And in fact, you want to avoid doing that because then you probably will end up with a withdrawing patient. But I think this makes the argument that there's a few select patients, for example, the patient in whom you have a very clear history of a massive overdose of a long-acting opioid like methadone or hydromorphcontin, where there might be a role for admission for observation, the same kind of way we would treat a patient with a history of long-acting Wellbutrin overdose. The third main consideration in deciding on discharge timing for patients is to think about the medical complications of an opioid overdose. So besides just apnea, there are a few medical complications to consider in the opioid toxic patient. One of the more common ones is demonstrated in this chest x-ray. So this is opioid-induced acute lung injury or acute pulmonary edema. This is a non-cardiogenic pulmonary edema, and it occurs in about 2% of severe overdoses. Now, clinically and radiographically, it looks very similar to acute pulmonary edema of any other cause, and the treatment is similar, mostly supportive care. More severe overdoses do seem to be more highly correlated with development of acute pulmonary edema. So in severe overdoses, monitoring patients for at least about 4 hours, which is the usual time frame in which this occurs, might be a reasonable thing to consider doing. Other medical complications to look for in opioid overdose patients would be fentanyl rigid chest syndrome, rhabdomyolysis, and ventricular dysrhythmias as well. Particularly methadone is bad for causing long QT. And finally, you have to consider your patient factors. Probably the biggest barrier you'll run into when it comes to trying to keep these patients in the department is just the patients themselves being unwilling to stay. And for a variety of reasons, whether they're worried about getting back to their families, losing a bed at a shelter, or just looking for their next hit of opioids, these patients are a bit difficult to keep in the ED sometimes. And unfortunately, you kind of have to just strike a balance with your patients between what's medically safe and what's reasonable to expect from your patients. And that usually involves a bit of a discussion. So taking all that into account, here's some kind of general principles I think we can use to guide our discharges. In a patient who is asymptomatic or very mildly symptomatic with an opioid overdose, and that means someone who did not require naloxone at any point, if they took an immediate release preparation, you can monitor them for about 4 hours. And if they took an extended release preparation, I would monitor for 12 hours. And at the end of that time, if they're still looking well, that's probably a reasonable time to discharge them. For a patient with a more severe overdose that actually requires naloxone, you'd ideally want to monitor them for 4 to 6 hours after their last dose of naloxone or after their IV infusion has been turned off. And finally, if you can't convince a patient to stay and you think that they're mentally competent to leave AMA, then your safety just really lies in your discharge instructions. So warn them about the risk of recurrent overdose symptoms, even if they don't actually use a drug again. Warn them about withdrawal symptoms, especially in the patient who received a dose of naloxone. And advise them around harm reduction and how they can optimize their safety when using drugs. And that kind of leads us into the next bit of the talk, which is about take-home naloxone kits. So this is a pretty new initiative in our ED and brought about thanks to Dr. Lisa Thurger here. But it's not a new idea overall. Take-home naloxone kits have been variably in use since the early 1990s for high-risk opioid users. In 2014, the WHO made the official recommendation in their guidelines for community opioid management that people who are likely to witness an opioid overdose should have access to naloxone and should be trained in its administration. In 2014, a systematic review of naloxone distribution programs was published in the Journal of Addictions Medicine. And that review looked at 19 different observational studies evaluating these kinds of programs. And they found that take-home naloxone programs were associated with improved knowledge about overdoses among the participants and improved understanding of naloxone and how to use it appropriately. A subsequent systematic review in 2016 was published in Addiction and looked at 22 observational studies from North America, Europe, and Australia. And they found that take-home naloxone programs led to improved survival rates among program participants, reduced overdose-related mortality rates, and was associated with a very low rate of adverse effects. Now, specific legislation across the country varies a little bit from province to province, but Ontario's had a take-home naloxone program in effect since 2013. And in March of 2016, Health Canada actually removed naloxone from the federal prescription drug list, with Ontario following suit a couple months later. So that means that in Ontario, people can obtain take-home naloxone kits from pharmacies or from community centers without any prescription required. So who's actually eligible to get a kit? The short answer is pretty much anybody. The Government of Ontario specifies that anyone who is currently using opioids or is a previous opioid user at risk of relapse, or anyone who is a family member, a friend, or anyone who might be in a position to help someone at risk of opioids is eligible to receive a kit. And again, that's with no prescription, and that's also with no fee. And I think those categories are broad enough you could probably slot almost anyone into them. But if someone wasn't able to fall into those categories, they're still eligible to get a kit. They just might have to pay a portion of the cost. And a typical kit costs about $35. So both of our EDs are stocked with these kits now. At the General, they're located in the big medication cupboard in observation. And at the Civic, they are in recess and obs in the nurses' medication areas in two of the drawers, which are known to everyone as the old narcotic drawers, which I learned this week. There's also a teaching kit there with the new kits, so you can look through if you want to see. And I grabbed a couple kits before the talk, if you guys want to look at them. So this is what our kit actually looks like on the inside. Each kit contains 2 1 milliamps of naloxone, so that's 2.4 milligram doses, 2 syringes, 2 safe ampule opening devices, 2 alcohol swabs, a pair of non-latex gloves, 1 rescue breathing barrier, and a set of instructions. And at our center, we're really fortunate that our nursing colleagues have all been trained in distribution of the kits and the education that goes along with the kits. So they can help you a lot with discharging these patients if you write the order for it. We're actually really lucky to have these kits stocked in our ED. Even major emergers in Toronto haven't been able to get these programs off the ground. But unfortunately, although we have access, we haven't really been taking advantage of the program. And our numbers suggest that since the program started, we haven't actually given out all that many kits from TOH. So that's another thing I hope you guys take home from this, is just to remember to think about take-home naloxone kits when you're discharging high-risk patients. The most obvious candidate is the patient who comes in to emerge in an overdose and gets naloxone. And I don't even think we're actually fully capturing that group. But even think about this in your patients who have a history of opioid abuse, even if they're here for a different reason, who are presenting with opioid withdrawal, or just patients who are on high doses of opioids for cancer pain or chronic pain. The bottom line is just have a low threshold to think about giving these out to anyone that you think might be a risk of overdose. Okay, so now that we've talked a bit about the rising opioid crisis and how to manage an opioid overdose, I want to finish the talk by discussing how to manage acute opioid withdrawal. And the reason I think this is important is that in the setting of this public health emergency, our ability as clinicians to treat opioid withdrawal well and help our patients link to addiction services will be really key in actually trying to solve the problem at hand. And the thing about managing opioid withdrawal is that there's really no cookbook or exact recipe that's going to work for every single patient. But the idea is that if you have multiple ingredients that you're comfortable with, you can play around with them and try different combinations and different doses to see what works for your patient. So we'll start with the ingredient that I think most of us are familiar with. I think this is what I've seen most of us prescribing in our department. Clonidine is a presynaptic alpha-2 agonist. It's not actually structurally related in any way to opioids, but there's a functional overlap between the alpha-2 receptors and the mu opioid receptors. And so in that way, clonidine helps to offset a lot of the withdrawal symptoms that we see in opioid-dependent patients. In terms of how to dose clonidine for the withdrawing patient, you'll see, again, a lot of different regimens, but a common emerge one would be to give 0.1 milligrams orally every 1 hour in the ED. And most patients will require 3 or 4 doses before they start to feel comfortable. And then you can send them home with a script for clonidine 0.1 milligrams TID for 5 days, followed by 1 dose at night for a week. No taper is necessary for that duration of therapy. Although it's our go-to drug in the ED, there are some downsides associated with clonidine. It can be somewhat sedating, which patients don't like. And it also helps with withdrawal symptoms, but not so much with the opioid cravings, which is a really big struggle for a lot of these patients. More importantly, though, it's just really hard to get patients to actually buy into taking clonidine. So most of our chronic opiate users have tried this before. They've been through really painful withdrawal, and they're not willing to risk that kind of pain for a drug that hasn't worked for them in the past. And they're probably not wrong, actually. For the highly addicted patient who's going to go into bad withdrawal, clonidine on its own is probably not enough to get them through their withdrawal. And here's why. If you think about this in the context of what you're actually trying to treat, it makes sense that clonidine alone is not really enough. So if you think about the classic withdrawal toxidrome for opioids, we think about hyperthermia, hypertension, tachycardia, yawning, piloerection. And clonidine does help to treat that withdrawal syndrome, which is helpful. But opioid withdrawal also comes with a bunch of other really uncomfortable signs and symptoms, like severe anxiety and insomnia, myalgias and bony pain, nausea, vomiting, and diarrhea. And clonidine doesn't do a lot to help with that aspect of the withdrawal. And that's where your adjunct therapy becomes really important. One of the more common meds we've seen used in acute clonidine withdrawal is gabapentin. So gabapentin, as we know, is a GABA receptor analog, and most of us are familiar with this medication in the context of treating neuropathic pain. But it actually has specific properties that reduce pain, diarrhea, and anxiety in the setting of opioid withdrawal. A reasonable starting dose is 300 milligrams 3 times a day, although you'll see some people who recommend even higher doses than that. The biggest rate-limiting step for dosing gabapentin is that it is also quite a sedating medication. So if you have a patient who's more elderly or who's on multiple sedating medications, you can think about reducing the dose, or you can just advise your patients about that so they can reduce the dose on their own if sedation is a problem. Another one to have in your back pocket is Tramadol. So Tramadol is a synthetic analgesic with both opioid and non-opioid properties, and it's a weak mu receptor binder. Now this one is a little bit more controversial. It does help with withdrawal symptoms, and it does help with cravings as well. And theoretically, it has less addiction potential than other stronger narcotics. But while we see a lot of addiction specialists using this, many toxicologists don't support its use for withdrawal because they feel that tramadol is still an opioid and you're ultimately just replacing one opioid with another opioid. It also comes with its own complications, including a potential for serotonin syndrome and decreasing the seizure threshold. So this one probably shouldn't be your first-line medication, but it's another one just to have in mind. And typically it's dosed as a 5-day taper, starting at 100 milligrams QID and tapering down to 50 milligrams on the last day. In terms of other adjuncts, this is really just basic symptom management. So for antiemetics, you can use Zofran and Stemetil. That's what's seen on most opioid withdrawal protocols and seems to work the best, but Gravol is also a reasonable option. Trazodone or Seroquel can be prescribed for insomnia or anxiety. Benzos will also work for those purposes, but again, I would just caution prescribing one addictive substance in replacement of another. So try to steer clear of benzos if you can. You can treat diarrhea with loperamide, and you can treat pain with your other non-opioid analgesics like Tylenol, Toradol, and other NSAIDs. So now, with just a few extra medications under your belt, and mostly things that we prescribe every day, we're able to treat our patients' opioid withdrawal much more effectively. So it's not that hard to do. You just have to think about what things you're actually trying to treat and make it a symptom-based approach. Prescribed appropriately, these medications can be very effective. But ultimately, this is kind of just a Band-Aid solution. What we really want is to get our patients into a long-term treatment program where they can get off of the addictive opioids. And not every patient will be interested in this, but for those who are, we now actually have a tool we can use from the ED to get these people long-term sustainable help. And with that, I'm referring to long-acting opioid agonist therapy. So that mainly includes methadone and buprenorphine, or Suboxone, which is buprenorphine combined with naloxone. For the purposes of this talk, I'm going to focus really just on Suboxone because that's what we prescribe out of our ED. That's what's most relevant to our practice. But for anyone who's interested, there are some good papers comparing buprenorphine with methadone. There's a Cochrane review in 2016 that found about equal efficacy between the two. And our own Dr. Isabel Miles also gave a great grand round specifically on this topic last year that you could look at. The reason Suboxone is exciting for us is that unlike methadone, you don't need any special licensing or special training in Ontario to prescribe it, as this is a tool that we can actually access. And as you hopefully know, at TOH we have a new emergency department Suboxone initiation protocol, which makes it really easy for us to do this. Suboxone is a combination pill, as I mentioned, so it contains buprenorphine, which is a partial long-acting opioid agonist, along with naloxone, and it combines them in a 4-to-1 ratio. And the combination is actually kind of genius if you see how it works. The idea with the combination is that it has far less abuse potential than either methadone or buprenorphine alone. As you may recall, naloxone is only 5 to 10% bioavailable in oral form. So if the Suboxone is taken orally as prescribed, the effect of the naloxone is effectively negligible. But if a patient is injecting or snorting or abusing the drug in any other way, then the naloxone component becomes bioavailable. And so that sort of negates the high as well as inducing potentially really unpleasant withdrawal symptoms. So it kind of acts as a deterrent for abusing the Suboxone the same way that antabuse would work for alcohol. And also, unlike methadone, Suboxone is only a partial opioid agonist, meaning that it has a ceiling effect. And that's important because there's a maximum effect it can have on your respiratory depression. So even in the event of an overdose, these patients rarely end up completely apneic. Several publications have supported the use of ED initiation of Suboxone. One recent article was published by D'Onofrio et al. In JAMA 2015. And this was an RCT looking at 329 opioid-dependent patients seen in the ER for withdrawal. The acute symptom management of withdrawal was left to the discretion of the treating physicians, but 3 different discharge strategies were compared. They compared immediate referral to addiction services, brief counseling in the department followed by referral to addiction services, and finally brief counseling plus Suboxone initiation and then referral to addiction services. And the study demonstrated that ED initiation of Suboxone significantly increased engagement of patients in their addiction treatment, reduced self-reported illicit opiate use during the program, and decreased the use of inpatient treatment services compared to the other 2 arms. So it also decreased the burden on our already overwhelmed detox facilities. So who is actually eligible for this program? Pretty much anyone who presents to the ED who's opioid dependent and in clinical withdrawal is potentially a candidate for this program. And the key point is they actually have to be interested in engaging in some kind of a long-term treatment program. So Suboxone is not meant just to be a one-off acute management tool. It's actually a program, much like a methadone program for getting off of narcotics. And by the same logic, if a patient is already on a methadone program, they should not receive Suboxone in the emerge. If they're interested in switching agents, they should talk to their methadone provider about that. Finally, the patient has to meet 2 clinical criteria, and this is the 12 and 12 rule. So in order to receive Suboxone, they must be at least 12 hours out from their last use of opioids and have a score of at least 12 on the clinical opiate withdrawal scale, which I'll show you in a moment. But it's important to recognize the patient actually has to be in active withdrawal in the emerge to be able to get Suboxone. So this is the clinical opiate withdrawal scale, or COWS, which is a commonly used validated scale to measure clinical opiate withdrawal. I know this slide is quite busy and difficult to read, but basically it's just a list of 11 different clinical criteria, including things like heart rate, GI upset, pupil size, and those are added together and scored, very similar to how a CWA score is used for alcohol withdrawal. And a score of 12 or more on the scale is considered moderate to severe opioid withdrawal. So this is our TOH Suboxone protocol. It's actually one of the shortest protocols we have in our department, which is nice. And it's pretty straightforward. These are available on MyTOH under EP resources. And there's also, I believe, printouts in binders in the OB sections of both campuses. So again, patients have to meet 3 simple criteria. They must not be on methadone, they must be 12 hours from their last dose of opioids, and they must be a clinical withdrawal score of at least 12. If the patient meets that criteria, they're given either 1 or 2 tablets of low-dose Suboxone, which contains 2 milligrams of buprenorphine with 0.5 milligrams of naloxone. And the decision to give 1 or 2 tablets, again, just depends on how sedated your patient is, how frail or elderly they are. It's more just patient factors that determine that. Adjuncts are also provided with this protocol, so the same kinds of things, antiemetics, antidiarrheals, pain management. And then the patients are monitored in the emerge and reassessed for a repeat dose every 2 hours until they either are clinically looking well or they've reached the maximum daily start dose of Suboxone, which is 8 milligrams of the buprenorphine component. So when your patient is ready for discharge, you just have to do 2 things. First, you fill out a short referral form to the Rapid Access Addictions Medicine Clinic, which is located downtown in the Market. And secondly, you write them a prescription for enough Suboxone to last them until their next clinic appointment. So during daytime hours, they can just call that number right from the ED and make an appointment. Or for off hours, you would just prescribe for the next walk-in clinic time, which is the next Thursday or Friday. And when writing the prescription, the total amount of Suboxone that they received in the ED becomes their total daily dose of Suboxone. So for example, if your patient received 1 tablet of the 2 milligram, 0.5 milligram Suboxone first, and then at their 2-hour reassess received a second tablet, then their total daily dose that you would prescribe would be 4 milligrams of buprenorphine with 1 milligram of naloxone. So you just add it all together. It's also very important that at the bottom of the prescription you write for daily dispensing to be witnessed by pharmacist, because Suboxone should be initiated as a daily dispensing drug. So how do you actually sell this to your patients? Most of us are not addiction specialists or trained formally in counseling, and we don't have a lot of time in our jobs. There are some really good tutorials on the TOH website and the CAMH website that go through some ways to steer these conversations if you're interested, but there's a few key things I think we can all say that would help. The first really important point is tell them this will actually treat their pain. While you might be thinking about all of the long-term personal and societal losses that happen due to opioid withdrawal, all that the patient in front of you is thinking about is how awful they feel and how much pain they're in. And so until you deal with that, it's going to be hard to talk about anything else. And the thing is, most of them don't realize that the pain they're feeling when they stop taking their narcotics is actually withdrawal pain, not pain that their narcotics are treating. So tell them that Suboxone will actually treat their withdrawal pain and will actually make them feel better, because that's often a bigger initial motivator for them. Secondly, the drug is reasonably affordable, at least for the few days to a week that they need before they are seen at the RAM clinic and discuss other options. So it's 50% covered under the Ontario Drug Benefit Program, which leads patients to pay about $1.50 per low-dose pill. And let them know, finally, that this prescription will help them regain a bit of control over their life. Most of these opiate-dependent patients are spending all of their time and energy just looking for their next hit of the drug. And so if you tell them that they can actually get their time and their life back, that's really valuable to them. Okay, so just to summarize this section, here's an example of some initial orders that you might write for someone in the ED who's withdrawing, and an example prescription that you might write. So this might be a good slide if you wanted to take a picture of it, or I'll send it around to you guys so you have it for dosing reference. And again, these are just examples of combinations. You can feel free to sub in or out other agents depending on your preferences or your patient preferences. Just remember to sort of cover all those symptoms. So in the ED, a good set of orders would be clonidine 0.1 milligrams every hour, and then all of your adjuncts, so Zofran, loperamide, Seroquel, Toradol, and Tylenol. And then when your patient's ready to leave, you would do the clonidine at the regimen we talked about, 0.1 milligrams TID for 5 days, and then QHS for 1 week. And then you could add on to that gabapentin, 300 milligrams TID for 5 days, and then your usual adjuncts, Zofran, loperamide, naproxen, and Seroquel for nighttime. Alternatively, as a discharge, if your patient is on the Suboxone protocol, you would just write the prescription for Suboxone. And usually those patients actually don't need a lot in the way of adjunct therapy, because the Suboxone itself treats almost all of the symptoms that we talked about. But of course, if your patient is having specific issues with anxiety or pain, you could prescribe at your own discretion. And just as an aside, I just want to say, if you look at the 2 different discharge prescription options, it's really clear which one of those would be easier to do for you. So if nothing else I've said today has convinced you, just think about getting comfortable with the Suboxone protocol, if only to make your discharges a little bit more straightforward. Okay, guys, thanks for bearing with me. We're at the end here. I just want to quickly sum up a few of the key points from what we talked about. So first, we talked about the Canadian opioid crisis, and really the take-home there is just that this crisis is real. It is here in Ontario now, and probably more is well on its way to us. So we've really got to be engaged and prepared for what's coming. We talked about management of acute opioid overdose in this context, and the key points there are always think about giving more naloxone than what we're used to. Think about the medical complications of opioid overdose and the altered kinetics in the setting of overdose. And always think about giving out a take-home naloxone kit if you think that it'd be appropriate for your patient. And finally, in the setting of opioid withdrawal, remember no more clonidine monotherapy. Think about your adjunct prescriptions. And in the right patient, really think about Suboxone. And take a minute on your next shift to just look at the protocol and get familiar with it. I think this is going to be the single largest public health emergency facing Canada in the foreseeable future. But again, this is more than just a public health problem. This is our problem as clinicians because we're going to be seeing the most extreme complications of this epidemic in our department. So now is the time to really get comfortable with the medications and the resources that we're going to need to manage these patients going forward. There's a ton more stuff we could talk about, but I hope this was a bit of a good refresher, and hopefully you got a couple of little pearls that you can add to your opioid management template. And most importantly, I hope this generates a bit of interest and discussion on this very important topic. So I just want to thank a few people who really helped out. Dr. Lisa Thurger, who supervised my talk, Jen Lepard, Hassan Sheikh, and David Gruber, who went through all my slides, Matthew, Justin, Carrie, Cortana, and Sabrina, who provided me with some great adjunct data for this, and Ravin, who's listened to me talk about fentanyl nonstop for the past month. And with that, I will take any questions, or we can have some discussion.